Hello, I'm presenting the case 39 pulmonary thromboembolism or pulmonary embolism. The disorder is pulmonary thromboembolism or pulmonary embolism or PE. My name is Paulson Elekuru. So, patient case introduction. The chief complaint, according to the patient, I have severe chest pain and I can't seem to catch my breath. I think that I may be having a heart attack. The history of present illness. Mrs. VA is a 30-year-old woman who presents to the hospital emergency room after experiencing right-sided sharp pain and constant chest and mid-back pain 1 hour 30 minutes ago. Patient described her pain severity as 8 over 10. The pain worsened without lying down or taking a deep breath and improved a bit sitting down. She had breathing difficulty but denies any chills, fever, or hemoptysis or vomiting blood. She claims 36 hours ago she just returned from Tokyo after a 13 hours flight. Pulmonary thromboembolism (PTE) or pulmonary embolism (PE), description and epidemiology. PE is the third commonest cardiovascular disease after coronary artery disease and stroke, with an annual incidence rate of 0.6 or less than 1 in 1,000 people, but it's very rare in the pediatric population with an incidence rate of less than 1 in 100,000 children. It's relatively more common in geriatric population ages 75 years and above, with 1 in 100 elderly people. There's an increased risk among inpatients compared to the general population, with incidence rate of 1% of all hospital admissions. It is thought to be underdiagnosed or insidious or silent, with only 30 to 45% of pulmonary embolism being diagnosed pre-mortem or before people actually died. The rest are discovered after the people have already died or post-mortem. 30% of recurrent rate happens especially when it is occurred unprovoked, and it occurs the likelihood of reoccurrence 2 years after the first after after being diagnosed. The greater risk factors include recent trauma, recent major surgery, obesity, pregnancy, hormonal therapy, like birth control, smoking, and certain cancers. Some people, their first symptoms is they just die suddenly, and that occurs in about 25% of people that develop pulmonary embolism. Pathophysiology of pulmonary thromboembolism or P at the cellular level. Most pulmonary embolism develop as a deep vein thrombi in the left extremities, especially in the calf veins, and followed by femoro, femoropopliteal veins, but it's less common in the iliac veins. Thrombosis originate around the region of low of blood flow, such as the valve cups and bifurcations, and then spread because of localized coagulability related to hypoxia and hemoconcentration. Less frequently, emboli develop in the upper extremity veins, mostly related to the use of central venous catheters, intercardiac devices, such as pacemakers and defibrillators, and also can occur as a result of tumor or venous trauma in the upper extremities. Pulmonary embolism caused by pelvic vein, deep vein thrombosis are most likely related to risk factors such as pelvic infection, pelvic surgery, or pregnancy. Certain deep vein thrombosis from lower extremities are associated with emboli leading to pulmonary embolism in 52 to 32% in 15 to 32% of cases compared to 6% for upper extremities. Although calf deep vein thrombosis rarely cause pulmonary embolism, one third may embolize into the central veins, which then with potential to migrate to reach the lungs. Typically, emboli dislodge from their source of origin and migrate via the right-sided venous system into the heart or right atrium, and then the pulmonary uh, arterial system. The pathologic implications of pulmonary embolism uh, range from asymptomatic and then uh, hemodynamic collapse, and which may lead to death. Although pulmonary embolism leads to impairment of gas exchange or hypoxia and hypoxemia, it is a consequent hemodynamic instability that actually leads to increased mobility and morbidity and mortality seen in pulmonary embolism. Clinical manifestation of the patient, the pertinent subjective data. The chief complaint, I have severe chest pain and I can't seem to catch my breath. I think that I may be having a heart attack. History of present illness as detailed above. Past health history, at 23 years old, the patient had a migraine with aura up to the present time. Uh, she had a history of mild endometriosis and endometriosis for 5 years. The patient had history of protein S deficiency, which is positive, which is a clotting problem. 2 years ago, she developed DVT, the first episode, and she was treated with 1 year warfarin. 1 year ago, she had acute sinusitis. At 7 year old, when she was a child, she had orthopedic surgery due to leg trauma. 10 months ago, she developed ovarian cyst, which was removed. Her family history includes father has hypertension and is alive. The mother is dead, related to metastatic cervical cancer at 49 years old. The brother is alive and well. There's no venous thromboembolism history in the family. Social history, uh, the smoking history, she smoked 12 pack year. Currently, she smokes 1 pack per day. She's a business executive with active travel schedule. She just returned from 13 hours flight from Tokyo, which causes uh, the suspected diagnosis of pulmonary embolism. Uh, she she doesn't use alcohol and IV drug abuse is negative. She take caffeine occasionally. Medications. She's on 30 microgram ethyl estradiol with 0.3 milligram nogesterol for 4 years now, which is hormonal therapy. Amitriptyline. She takes Cafegot. She takes for migraine headache. She takes metoclopramide and ibuprofen for menstrual cramps. She takes multiple multivitamin, 1 tablet. Uh, she denies use of herbal products. Allergies include Demerol and sulfur-containing products. Pertinent objective data. General appearance of she's a well-developed white woman. Uh, she appears slightly anxious, no apparent distress. Vital sign as shown in the screen. Physical examination, review of systems. She denies cough or hemoptysis. She denies headache or blurred vision. She denies any auditory complaint, lightheadedness, extremity or neurology complaint. Constitutional, all other systems are negative. Neurologic, HENT, neck, lymph node, GIGU, pulse, ROM, joint, they are all within normal limit. Respiratory, lungs, chest, and breath within normal limit, except there is a subnormal diaphragmatic excursion. Cardiovascular, she has a rapid but regular heart rate. Neuros, she's alert and oriented times 3. Musculoskeletal skin, lower extremity and upper extremity. There's a left lower extremity tavinous vein, which is prominent and visible with multiple varicosities bilaterally. She has peripheral pulses, 1 plus bilaterally. Uh, Extremities Low extremity, they are cool to touch. Diagnosis and laboratory blood test results, they are shown on on the screen. Uh, Electrocardiography, she has sinus tachycardia. Echocardiography, ventricular wall movement is within normal limit. Lower extremity venous duplex ultrasonography shows left lower extremity and right lower extremity venous narrowing and prominent collateral vessels, and an incomprehensibility of the deep venous system in the popliteal veins. This is consistent with bilateral DVT. Uh, Ventilation perfusion scan. Uh, there's a perfusion defect at the right base of the lung. Uh, Ventilation perfusion mismatch of right lung, suggesting an intermediate probability for pulmonary embolism. Pulmonary angiogram shows abrupt arterial cutoff in the right base of peripheral vessel. The role of the advanced practice nurse underpinned by the Christian worldview. The APRN's purposeful course of action includes the following. The APRN provide insight into the pathophysiology of pulmonary embolism for risk stratification of patients to select treatment modalities, which include exclusive anticoagulation therapy, systemic thrombolytics, catheter-directed therapies, which include thrombolytics or mechanical thrombectomy or surgical intervention. APRA identified the multifactorial risks for developing PE by considering both the more prevalent acquired risk factors and the subtle inherited risk factors that are easy to miss, including prolonged immobility of pediatric patients and long-term use of oral contraceptives. Number three, the APRN integrate diagnostic testing and identification of no specific signs and symptoms to rule out or rule in pulmonary embolism. The APRN applies strategies for diagnosis aided by clinical prediction rules and risk stratification, including utilization of two-tiered Wells criteria and pulmonary embolism rule-out criteria to minimize unnecessary diagnostic testing. The API uses computed tomographic pulmonary angiography (CTPA) and chest X-ray to rule out respiratory conditions like uh, COPD and other respiratory conditions. Number five, the APRN consider estimating factors including age, comorbidities such as cancer, and availability of resources to select client-specific treatment based on diagnosis. The APRN established treatment approaches using assessment, clinical judgment, and the determination of the patient health status, including hemodynamic stability that may warrant anticoagulant therapy or otherwise thrombolytic therapy if the patient is hemodynamically unstable. And the next page is questions. Question one, highlight five major risk factors of this patient for pulmonary embolism. Question two, will you consider that this patient's plasma D-dimer concentration is negative or elevated, and why? Question three, what's the likely reason for respiratory alkalosis in this patient? The next slide, the last slide is the references. And thank you.